We're going to restart the session again. We're going to have Dr. Mariana Markell, our Director of Kidney Transplantation, here going to talk about adverse social determinants on kidney transplant outcomes. Thank you, Dr. Markell.
Thank you, Dr. Suresh. Okay, I'm going to start with a fictional case study. And I want you to think about this throughout my talk today. I'm going to bring this person back at the end, and you can think about where social determinants may have played a role in the ultimate outcome. So a 75-year-old male with hypertension, type 2 diabetes, and diabetic retinopathy has been on hemodialysis since 2016. He was initially referred at the age 69, but didn't complete the workup. He was then lost to follow-up. So think about all the time that's now transpired. In 2020, he had COVID and he subsequently refused the COVID vaccine. He did finally complete his workup after he was re-referred in 2022, and he received a deceased donor transplant after being listed for about 6 months. 1 month after the transplant, his son, who'd been driving him to visits and helping him with medications, decided to take an extended vacation. The patient then, I'm getting a funny Zoom thing here. The patient missed his follow-up visit and did not show up, and did not answer his cell phone, which was the only number in the chart beside his son's. He was brought to the emergency room by EMS with fluid overload and was found to have a hemoglobin A1C of 12.5 and severe antibody-mediated rejection requiring hemodialysis. When asked why he had not come to clinic, he stated, "I had no way to get there." So we're up to the fact that the patient has come to the emergency room with a hemoglobin A1C of 12.5 and severe antibody-mediated rejection, which required hemodialysis. When asked why he hadn't come to clinic, he said, "I had no way to get there." When asked why he didn't answer his phone, he said, "My son usually shows me how to use it. Why didn't you call the other number?" So, this may sound like an overly dramatic case presentation, but it's basically a consolidation of several cases that we've had where outcomes have been determined by adverse social determinants. So social determinants can affect not only access to transplant, including referral, attitudes toward living donation, and completing the workup, but continued listing as well as post-transplant issues. And just to remind you what social determinants of health are, this is the basic social determinants. There are more, but basically the neighborhood and the built environment. There are 5 basic social determinants, and those are the neighborhood and built environment, economic stability, education, social and community context, and health and healthcare. I will not talk about health and healthcare today, which includes things such as structural racism, other aspects that have to do with the healthcare system itself. But the other 4 are all areas that have definite impacts on our long-term, both our access to transplant as well as our outcomes. So the first one I'm going to talk about is social and community context. Social and community context affects willingness to accept a transplant, and especially a living donation. It can affect adherence to medications, which is due to belief systems about medications, as well as reliance on authority figures. It can affect adherence to dietary guidelines, which can have effects on cardiovascular and other outcomes. And those include the impact of ethnic and cultural dietary traditions. And this is a study that looked at demographic and social factors that predicted the likelihood of receiving a kidney transplant. And you see, I have several of these factors that are in with red arrows. Lower income, less social support, greater religiosity, and less transplant knowledge are some of the social determinants that were found to be important in actually getting a transplant at all. And, as a center that's very interested in increasing access to transplant, these are all things that we've looked into. So one of my students over the summer looked at religiosity in our patient population and found that it's very important. You can see here in terms of seeking spiritual guidance and making decisions that over half of the percentage of the patients that we interviewed either agreed or strongly agreed with this. What we also found was that the patients who sought spiritual guidance were more likely to have a negative view of medication. They also were less likely to believe that medicines protected them or that their health depended on them. And this is both dialysis and transplant patients that we interviewed. And they also believed that doctors used too many medications, that natural medications were safer, and that medications did more harm than good. So all of these beliefs may impact on long-term adherence. The other thing is in terms of dietary adherence, and you'll hear about that later from one of our dietitian, there's definitely an impact of social shared expectations and the social norm that impacts patients' ability to follow dietary guidelines. The neighborhood and built environment also has impacts on long-term transplant survival as well as access to transplant. It affects the ability to get to the transplant center. It affects the ability to complete the pre-transplant workup. It affects the ability to attend post-transplant follow-up clinics. And finally, it affects the ability to follow dietary and lifestyle recommendations that we make for continued health post-transplant. There's a quote that says, "Our zip code may be more important than our genetic code." And that's because patients who live in what's called a food swamp, where there's an easy availability of fast food and cheap alternatives, have a very difficult time in actually adhering to dietary advice and may have more of a tendency for worse diabetes control, hypertension control, and other aspects of cardiovascular risk that could impact long-term transplant survival. There's less opportunity for exercise and difficulty in accessing transportation. And just looking at the effects of some of the issues that affected access to transplantation in the South, you'll see the top two include transportation, which is what I just referred to, as well as low health literacy, which I'll discuss in a few minutes. So all of these things, distance to the transplant center, all of these things actually affected access to transplant in that population. And in terms of the built environment as well, when there's poor built environment, there's an increased risk of traffic accidents. There's a decrease in physical activity. All of these things may impact cardiovascular disease risk factors. As I said, there's fewer people walking. There's an increase in obesity and hypertension, and there's a difficulty in attending medical appointments due to difficulties in transportation. And here I just want to point out that East New York, which is where our center is located, is actually the biggest food swamp in New York City. This is an old map, but these are all fast food restaurants within our region. There was a 14% increase over 10 years. In zip code 11207, there were 27 fast food restaurants and 14 in 11208. And in fact, living in a food swamp may be as deleterious to your health as living in a food desert, which is defined as the inability to access a large supermarket where foods tend to be lower in price, less than a mile from your house. And in fact, East New York is not a true food desert, but it is definitely a food swamp, as is much of New York City. The other issue in terms of the neighborhood and the built environment includes housing and safety. I don't think I need to tell anybody who lives in New York City that exposure to crime and violence is an everyday event. If you use the Citizen app, it seems like it's constantly going off. There are long-term effects of children who are exposed to these things. They increase what are called childhood adverse events, which are associated with all sorts of diseases, including obesity, diabetes, depression, and substance abuse. There tends to be a lack of social cohesiveness, although that's not necessarily true in our population. And there are large numbers of people living in small spaces, which was extremely important during COVID, where there's an increased chance for disease spread. There's an increase in stress and an increased potential for domestic violence. All of these things can have effects on our long-term transplant outcomes. Then there's economic stability. Economic stability obviously increases the risk for food insecurity. It affects the ability to afford not only healthy food, but also follow the dietary prescription. It affects medication adherence and follow-up, and it also affects housing security. So you can see all of these determinants are intersected, and it's hard to tease one apart from the other. In Brooklyn, there is the highest rate of food insecurity in all of New York City. There are more people in our catchment areas who skip meals than any other area in New York City. And I'll show you that this is where we are in this red area here. And again, just showing it another way, that the food insecurity rate, and this is very old data, it's from 2017. It has not really changed. If anything, it's gotten slightly worse recently, but the food insecurity rate is higher than any other borough in New York City. And the thing about food insecurity that can have an impact long-term on disease is that foods insecure people tend to eat more highly palatable, nutrient-dense food. It's cyclical and related to SNAP or supplemental nutrition assistance benefits. More food tends to be available at the beginning of the month. Cyclical stress from food insecurity has an effect on the hypothalamus. It increases cortisol. And of course, as you might suspect, it can cause weight gain and poor control of type 2 diabetes and worsening of cardiac risk factors. So there's basically a cycle of stress that occurs with food insecurity, where there's poor dietary quality and eating behaviors that leads to chronic disease, including kidney disease, that also leads to increase in healthcare expenditures, decrease in household income, and feeds back again on food insecurity. In our population, I'm sorry, this is not ours, but food insecurity also leads to increases in hypoglycemic episodes because of differences in the ability to access food throughout the month. It leads to higher emergency department utilization. In people with diabetes, they tend to have a higher hemoglobin A1C, and their BMI is higher, even though you would think someone who's food insecure might be thin. They actually aren't necessarily. You cannot assume by looking at someone that they're food secure. It relates to poor health-related quality of life, and certainly an increased reported difficulty following a healthy diet. So patients who are food insecure tend to have a lower fruit and vegetable intake. And this was a study that was done by my students on some of our CKD and transplant patients. And these patients, 47% of them were receiving SNAP benefits and 23 were not. Actually, the people who received SNAP did eat more calories, but they ate more fat and less fiber than those who didn't. And the ones who reported food insecurity, actually who received SNAP, still ate more calories than the patients who did not receive SNAP, and more protein, but there was no difference otherwise. So in essence, the SNAP recipients also had a lower education level than the non-SNAP recipients, and they were more likely to be unemployed. The kidney transplant patients and the CKD patients who received the benefits, as I said, had a higher calorie and fat intake than non-recipients. And so they actually had worse dietary patterns, which has been reported in other populations, including low fiber intake. And then in terms of medical adherence, this is another study that was done by my students looking at 24 dialysis and 16 kidney transplant patients. In our population, over half of them reported an income of less than $40,000 a year, and 57% had not attended any schooling after high school. Many of them, and this is the absolute number out of 40, almost half of them said that finances affected their medical condition, and many of them reported difficulty with affording housing and difficulty with their monthly bills. What was more concerning was that it looked like patients had some impact on their ability to actually adhere to their medication. Now, the good news was that almost half of them never missed or forgot medication, but the bad news is that more than half of them had either intentionally missed a dose or forgotten a dose, or made medications last, skipping a dose because of financial issues. And the people who made their medications last as long as possible, even if it meant skipping a dose, were the ones who had difficulty meeting monthly payments and affording their housing. In addition, the ones who reported more difficulty meeting their monthly housing reported more difficulty affording, more concern about financial costs associated with their medications. So finally, I want to talk about how education may affect access to transplant or transplant outcomes. And I think this was mentioned slightly in the morning by the speaker who talked about the impact of education on undocumented patients. So medical literacy, health literacy is defined as the ability to obtain, read, understand, and use healthcare information in order to make appropriate health decisions and follow instructions for treatment. And health literacy is something that's very important in long-term outcomes. Nutrition literacy includes the ability to obtain, process, and understand basic nutrition information, and they tend to be related. There's also something called numeric literacy, and that there are patients who are unable to add or subtract, which can have an impact if you change medication doses or ask them to follow certain dietary prescriptions, as you'll see. So again, as I said, medical literacy can affect the referral for transplant. A patient may really not understand the benefit of transplant. It can affect the completion of workup. They may not understand why they need a colonoscopy or why they need cardiac workup. It can affect medication adherence, where they don't really understand why they need to take a particular medication. And as you see, some of them rely on outside sources for education about their medication, and those outside sources may not really understand. Numeric literacy, as I mentioned, can also affect numeric medication and dietary adherence. And then there's something that we have been very interested in that's been somewhat overlooked, and it's called e-health literacy. And e-health literacy is the ability to use, say, the internet or your cell phone to access things like, say, medical records or prescription reminders. And I'll show you some data from our patient population that our e-health literacy in this population is extremely low. So the way medical nutrition literacy can play a role is it may be a patient has decreased visual ability. People who have diabetes or the elderly may be sight impaired and the font on their prescriptions may be very small, or they may not be able to read food labels. They may speak a language other than English, which was alluded to also this morning, and things may not be translated, so they truly don't understand what you're saying. They may not be able to read, and they may be too embarrassed to tell you that they can't read. So you give them handouts, but the patient is unable to read it. They may be unable to understand portion size or calculate nutrient intake. Many years ago, we did some studies asking patients who'd been counseled every month in their dialysis unit about how much sodium they were supposed to eat. None of them could recount how much they were supposed to eat correctly. And medication dose changes also may be difficult for patients if they're not numerically literate. So when we looked at nutrition literacy in our population, we used something that I'll show you called the Newest Vital Signs Toolkit, which is very easy. And the mean literacy score was 1.93 plus or minus 1.8. That's out of a score of 6. It's extremely low. Only 17 of the patients scored greater than 4, and over 80% were considered at risk for nutrition illiteracy. And this is the test that they were administered. They're just asked to read a food label. There's a new one now where this is a bit larger so that they can see it. But they're asked to do things like calculate how much, if they ate the entire container, how many calories would they eat? You notice obviously here that it says 4 servings per container. Many patients are unaware. They may just read, oh, this is 250 calories and eat an entire container of something. There's other questions about having to do with if your doctor asked you to decrease the amount of saturated fat and you ate this, how much would you be able to eat? How much is left in your diet for the day? If you eat 2,500 calories, what percentage of your calories will you be eating in one serving? I mean, this is just reading it totally off of the label. And our patients were not able to do that for the most part. Then, as I mentioned, electronic health literacy is something that we've recognized as an issue recently. We looked at 38 kidney transplant recipients and 31 hemodialysis patients, and we used something called eHeals, which is an electronic health literacy survey. It utilizes 8 quick questions and is scored between 8 and 40. Of our patients, 97% owned a cell phone, 91% owned a smartphone, but 21% had no home internet access. And the mean eHeals score for our transplant recipients was 23.7. And I will tell you that out of a score of 40, that's considered poor. There was no difference in our hemodialysis patients, not surprisingly. So what we also found is that 61% of them reported needing help to access the internet, if they even had the internet. And the mean eHeals score, not surprisingly, was lower for those patients. It was 21.6. 100% of these patients, in terms of televisits, because I know we're trying to move toward televisits, 100% of the patients who had not had televisits were extremely, versus 24% of the patients who had televisits needed help. So it looked like the reason people weren't having televisits in part was because they simply couldn't access the internet. And the mean eHeals score for those who did not have televisits was lower overall than those who did. And you can see it's extremely low, 18.9. So if you think about it, we have a lot of wonderful new apps and reminders and things for our patients, but many of our patients can't use those apps, or they can't use those programs. And again, this is a situation where especially an older patient may be embarrassed to tell you that they simply don't understand what you're talking about. However, we found a very, very interesting thing, which is there's a simple way to know how literate your patient is. When we basically asked them how many times a week did they send a text message, 26% of them reported never sending text messages and 27% fewer than 2 to 3 times a week. 64% didn't use any mobile health apps, and 45% reported having trouble downloading any apps. So using a generalized linear model, Basically, what we found was that the eHeal score was associated with their frequency of text messaging, and that was even after controlling for age, education, and clinic setting. So if you want to know if your patient will be able to use some of the things you're recommending, and you ask them how many times in the past week did you text message, and they say never or 2 to 3 times, you can be pretty sure they don't really know how to use their cell phone. And that was a really very interesting finding, which we've now repeated. So I hope you realize that recognition of these adverse social determinants is really the first step in removing some of the barriers to successful transplantation, not just in referral, but also in long-term outcomes. So what do we do? This is adapted from the obesity research, but there are peripheral strategies such as education programs at churches, barbershops, and through radio stations. And we're in the process of working with the Y and some of our local groups to do some education for our patient populations as in terms of access to actually getting transplantation, especially living donation, using logos, artwork, and colorful designs, and getting constituents involved, including focus groups, community advisory boards, and then healthcare professionals from similar backgrounds to the patients whom we serve, as well as peer mentors and educators. And we're hoping to revive a program we had where it was a support group for kidney patients that included both dialysis and transplant patients. The other thing, and I think this was alluded to also this morning, is to make sure that your materials are adapted for linguistic ability. And we do have a video which we're in the process of translating into Spanish and hopefully Creole eventually. We recognize that this is definitely an area, and we use translators in our clinic, and some of us are Spanish speakers. Sociocultural strategies, including recognizing the importance of spirituality, religiosity, and faith, and working with local faith leaders, examining and enlisting family and social support, appreciating cultural images such as attitudes toward body image, as well as cultural dietary habits, and then working with local government agencies to try and remove the barriers to transplant that you heard this morning. So I want to get back to our case study and now think about him. This was a 75-year-old male. He has several medical diseases, including retinopathy, and he's been on dialysis for quite a long time. He was initially referred a long time ago, but he didn't complete his workup. So who knows what the issues were there, but there were probably some barriers that were the reason he didn't complete his workup. He's a patient who refused the COVID vaccine, which could be what we call, it's not a red flag, but maybe a pink flag in terms of beliefs and working within the healthcare system. He did complete his workup after he was referred in 2022 and received his transplant. But his son, who was his source of support, decided to take a vacation. And this is actually based slightly on a patient that we've actually had. It's these support people, especially in someone who may have limited sight and possibly limited literacy, are very, very important in the long-term transplant follow-up, and our social workers will be speaking to you about this later. He missed his follow-up visit. He didn't answer his cell phone, and that was the only number in his chart. Why did he not answer his cell phone? Again, this may get back to health literacy. He may not have known how to answer his cell phone. His cell phone may not have been charged. His son wasn't home. And finally, he came to the emergency room, and at that point, it was too late. He said he had no way to get there. His son had left. He had a transportation issue, and he didn't understand why they didn't call his landline because he doesn't use his cell phone very much. So these are all issues that play into long-term transplant outcomes. So in summary, I hope I've illustrated that adverse social determinants may underlie some of the disparities, both in referral for transplant as well as in actual transplant rate and even long-term graft survival. Social determinants can have deleterious effects, as I said, on short and long-term, both allograft and patient survival. So it's very important to educate patients so they understand the medication regimen and are able to take their medications correctly. And we have several checks and balances, including large print paper that we give to patients in their clinic visits every time a medication is changed. Things like financial stress, and you'll hear from our financial coordinator in a couple of minutes, ability to get to clinic appointments, beliefs about their medications, and this is something that's maybe subtle, worsening of their cardiovascular risk factors due to inability to follow dietary and lifestyle recommendations, and inability to access their medical history or communicate quickly with them through apps or electronic devices. So in conclusion, screening for adverse social determinants and working together with our social workers, pharmacists, dietitians, finance managers, and community resources can help offset these remedial issues that affect our underserved population. And I hope that these will allow us to remove barriers that are not only to the transplant itself, but to their long-term graft and patient survival. Thank you.
Thank you, Dr. Markell.